So we're going to be doing a case-based discussion on functional GI disorders, and I'd like to introduce our panelists. So Dr. Lin Chang, at the end, she is our vice chief for the UCLA Division of GI, as well as she's our program director for our fellowship program. Dr. Kirsten Tillisch, in the middle. She is the chief of integrative medicine for the Greater Los Angeles VA and also an associate professor of medicine at UCLA. And Nancee Jaffe, she has helped start and run our digestive health and nutrition clinic at UCLA. So we're going to try to touch on a lot of different topics, including mind-body therapies, medical management for functional dyspepsia, constipation, IBS, also when to use the low FODMAP diet and how to advise patients on fiber intake and probiotics. So we're going to start with the first case. This is a 28-year-old female who comes to the office complaining of upper abdominal bloating, fullness, nausea, and pain associated with early satiety that occurs most days after meals. She said 2 years ago she hiked the Inca Trail, and during that trip she got quite ill with vomiting, diarrhea, and she took 3 days of ciprofloxacin that she had with her on her trip. When she came back, she had stool studies done that were negative and no additional treatment was given, but she says that her stomach's just not been the same. Ever since she came back, she feels that after she eats, she gets uncomfortable and full. She develops bloating, pain, and nausea, and these symptoms occur at least once a day. She denies constipation or diarrhea, and she thinks because she's been feeling full and having this discomfort, she's been eating less, so she's lost about 5 pounds. As long as she doesn't eat, she's fine, but if she does eat, she gets this epigastric pain and bloating that does not improve with bowel movements. She only rarely has vomiting, only if she drinks alcohol. She's had some relief with ginger and peppermint, and she's tried eliminating gluten and dairy, LA diet here, without significant improvement. Her past medical history is mostly notable for that she had bulimia in college. She was put on an SSRI for 2 years, stopped that after graduation. She works as a writer for a television show, which is extremely stressful. She does manage to exercise pretty much most days. Her mother also has a history of anxiety and depression, and a sister who has a sensitive stomach. Her physical exam is pretty much unremarkable, no significant pain or tenderness. So at this point, I'll ask our panelists, what workup would you recommend at this point?
Yeah, so she certainly sounds like she has post-infectious functional dyspepsia. The only things that might be of concern at this point would be that she's still losing weight 2 years after where you would think she might have stabilized. It does seem like she's doing this because she's eating less, but it is a bit of an alarm feature. She's been anemic. We don't know why. And so, and also, even though she doesn't have diarrheal symptoms, infection can sometimes be a trigger of celiac, sort of the onset of celiac. So probably I would look for celiac. I'd see if she's anemic now, because she's been anemic in the past. And the diagnosis of functional dyspepsia really is confirmed with a negative endoscopy.
Yeah. Which she did end up having. So she
had test her for HP, and you would test her for HP.
Exactly. So, so she did have her upper endoscopy with biopsies that were negative for H. pylori. She was ruled out for celiac with a blood panel. She also ended up having an abdominal ultrasound and a gastric emptying study that were both normal. And she was put on a trial of PPIs for about 4 weeks to see if that was something that would help her, and it was not. Is that something that you would do?
Well, I probably would do it since she has epigastric pain. If she had just postprandial symptoms that are non-painful, you usually don't give a proton pump inhibitor. But if there's pain, which she has, I know it's most postprandial, yeah, you would give a trial.
Great.
I think in this patient also with a history of bulimia, it's a difficult topic for people to talk about. And I've certainly had patients who have eating disorder history who have relapses but come in instead of discussing that relapse, discuss the symptoms that they have. And so that would definitely be something that I would probe with the patient sometimes refer to mental health.
So that is actually one of the things that was done. She was referred to psychiatry to see if there was any element of an ongoing eating disorder, and it was felt that she did not have persistent abnormal eating. So you had already mentioned the diagnosis of functional dyspepsia, and I wanted to know if one of you would comment on the different subtypes of epigastric pain syndrome and postprandial distress syndrome and the importance of defining that in this patient as far as how it affects treatment.
Yeah, well, that's been somewhat of a debate, but there's been some studies where they've looked at different populations of patients, and they seem to cluster in these two subtypes. You know, it used to be called in the old days ulcer-like pain and motility-like dyspepsia, functional dyspepsia, but now it's epigastric pain syndrome, postprandial distress syndrome. What they found between the Rome 3 and Rome 4 is that a lot of these patients will have postprandial symptoms. And when you have that group with the postprandial symptoms, then it's called postprandial distress syndrome. And then patients who have predominantly epigastric pain, which is at least 1 day a week. Postprandial distress syndrome is more 3 days a week because it's more common like this patient. Now, what you show though is that a lot of people have overlap. So what you look at is the predominant symptoms. So if most of the symptoms are after meals, even though they may have some pain, you call it postprandial distress syndrome. If they have mainly epigastric pain, that's predominant symptom, and it's not necessarily related to meals, it's called epigastric pain syndrome. And now there's been studies where they're taking one type and studying the treatment. So I think, and some people do have an overlap, because that's really the issue, right? Is their pathophysiology really different, and would you treat them differently? And it turning out that you probably would, but I think there's definitely overlap.
So in this patient, you would say that she had postprandial distress syndrome.
Yeah. If she had pain that was strong, that was unrelated to meals also, she could have an overlap.
Yeah. So for her on discussion, she really feels that anxiety contributes to her symptoms. It impacts her social life. She acknowledges some anticipatory anxiety about food because she worries if she goes out with friends, she's going to get a flare-up of this pain and this bloating. So at this point, she'd really prefer to treat her symptoms without medications if possible. And so the question is, what would you recommend at this point if she presents to you asking for treatment that does not involve medicines?
So from a dietary standpoint, the research has shown that giving these patients smaller, more frequent meals can be very helpful. We also find a lot of patients, especially if it's postprandial, the amount of fat seems to play a big role. When they've done studies where they've asked patients what foods they felt like contributed to symptoms, they said things like bell peppers and cucumbers, which is kind of interesting, and I do see that in my practice. And then, of course, there are some herbal remedies that we can use with patients that have been shown to be helpful, like peppermint with caraway, or even certain herbal complexes that are from Europe.
Great, thank you. And to touch on some of the mind-body interventions, we're going to jump to that. I'm going to introduce Kirsten Tillisch to give us an overview on that.
So this is the kind of patient who is coming to us asking for something that's non-pharmacologic. So it's a pretty easy jump to say, okay, well, let's talk about potentially food supplements, probiotics, herbals, dietary changes, but also she brings up her anxiety. And so this is a natural fit for somebody who we might want to use a mind-body intervention, knowing the clear connection between the brain and the gut symptoms. When I see patients, though, sometimes they might not be asking for this, but I tend to use mind-body interventions early on rather than waiting for one thing after another to fail. If I can identify this pattern in a patient, even when they haven't identified it themselves, I'll often start with a mind-body intervention rather than starting with medicines, or do it together to see if we can get them improved early. So why do we do this? I think most people are aware of the connection between the brain and the gut. I don't have an easy pointer, so I won't be able to point to my slide. But what I do with patients is not explain in detail the pathophysiology of mind-body interactions, but explain it in a simple way. We have the brain, we have the gut, we have the nervous system, so the autonomic nervous system that impacts our immune system, and it impacts our gut through the enteric nervous system. It can change our immunity, our motility, secretion, and pain sensation in the gut. And so we know that there's this top-down effect. And most people can recognize it. We give them examples. We also know now that it goes the other way as well. And so those changes down from the brain affect how the gut functions, affect how the microbes live within the gut, and those changes feed back to the brain and actually feed changes in emotions and cognitions. And patients often are very receptive to this idea that when they feel poorly, it actually drives their anxiety. And then their anxiety drives feeling poorly. And when you can identify that for them, it really brings them on board with trying something that's brain focused. And if we don't do that, we often have a patient that just feels like we're sending them away. Go do something with somebody else, because this is all in your head. That's the last thing we want to do with our patients. We want them to buy in. One of the things that we'll often recommend would be hypnotherapy. And this is something that people find a little daunting often. They think about a hypnotist, they think they're going to be losing control, there's going to be somebody swinging a pendulum, they're going to go unconscious, wake up, and who knows what they may have done. And medical hypnotherapy is nothing like that. So it's pretty straightforward. Gut-directed hypnotherapy has been studied for many years now. It basically is a state of focused attention in which relaxation can occur and positive suggestions for health are given. And when it's broken down, it can actually look really simple and almost like, how could that work? I know when I first learned these protocols, I was blown away that there was data supporting their benefit. But after a decade of using this with many, many patients, I find that it's incredibly effective. So we let them know, they'll talk you through a gentle relaxation and give positive suggestions to change sensation and to increase acceptance of those sensations that you have. And so one of the examples of that is used often in hypnosis is like a volume control. So we have the patient that comes in that has 11 out of 10 pain. And we see that frequently. During hypnosis, they actually visualize turning the pain down with a simple knob as an image, if that works for a person, or sometimes using it in color, going from bright red down to a gray, and actually sensing that during hypnosis, that they can control that pain. It sounds simple, it works. The nice thing about hypnosis is it's a standardized set of treatments, so when you send somebody out, you can say, well, this will be between 8 and 10 visits usually, sometimes less, sometimes more, but standardized protocols work that way. And it's over a couple months. It can be done individually, which is most common. There's some data that shows that it also can be done in groups fairly effectively, not quite as much benefit. And then everyone does self-hypnosis as well. You send them home with a tape of the hypnosis. They do it daily. Some people will do just the tapes, not as effective as working with a practitioner, but better than nothing. Data shows that compared to a placebo pill and supportive care, hypnosis can improve general well-being, bowel symptoms, bloating. And follow-up studies show that these benefits remain years after they complete this 2 to 3 month therapy. It turns out in functional dyspepsia, as well as in irritable bowel syndrome, there's some data that show that hypnotherapy compared to supportive treatment or medication causes a prolonged benefit in symptoms. And in kids, in both functional dyspepsia and irritable bowel syndrome, there have been benefits. Some early studies have looked at this in inflammatory bowel disease as well and shown some benefits in quality of life. So how might this work? What we understand from the studies of the brain in IBS is that it turns out that expectation of pain is one of the most important things that goes on. This is the hypervigilance and anticipatory anxiety. And this image shows, in the first panel, a normal person without IBS having response to a painful inflation, expectation of a painful inflation in the rectum with a balloon. In the middle is someone who has IBS but isn't hypersensitive to visceral pain. And then the last panel, someone who is hypersensitive. And you can see the ramp up in those red colors in the area that we call the insula, and the inclusion of additional regions in someone who's hypersensitive. So they expect pain, the brain is acting. What about if they go through hypnosis? So here is before hypnotherapy, the first panel, that expectation of pain. The second panel, the actual inflation of the balloon, so where they're actually feeling pain. And then after hypnotherapy, you can see, if you remember back to that first picture, they look just like the healthy person without IBS. So what hypnosis does is it changes the brain's response to expectation of pain and to pain delivery. And I find it helpful to explain that to patients in a simple version. The most difficult thing is, how can we find somebody who does this? There's not a lot of therapists who are trained this way. You want to make sure that you're sending somebody to a licensed healthcare professional who is going to know how to do gut-directed hypnosis. So you want to assess for somebody who has some formalized training and is familiar with the standardized protocols to use for IBS. I send people to this website, ibshypnosis.com. This is done by Oliver Paulson, who's at University of North Carolina, Chapel Hill, and did a lot of the research in this area. And it lists by state and city practitioners who use these protocols. I find it helpful to work closely with a practitioner so that I know that I'm working with somebody who is good at this. So gut-directed cognitive behavioral therapy is the other common thing that is done. And a fair amount of research for irritable bowel syndrome, less so for functional dyspepsia. But for a patient like the one we just talked about, might be a really good fit. Somebody who's very aware of their anxiety and may be able to work through this with cognitive tools. So this is also a time-limited intervention. It tends to be done over the course of a couple months, so we're not sending someone to a therapist to talk about their early life or their people at work or their interpersonal relationships. We're sending somebody to a specially trained therapist to talk about their bowel symptoms and learn specific skills to manage those symptoms in the real world. So there's behavior modification. And there's identification and adjustments of dysfunctional thought patterns. And so those kind of thought patterns on the most simple, basic level would be, I have a sensation in my stomach. I woke up, I have a little pain today. Gosh, is it going to get worse? What about when I eat? When I eat, it's probably going to get worse, and I'm going to get bloated, and I won't be able to get into my clothes. And maybe I just won't even go to work today, but I've used most of my sick days, and my boss is already mad at me. I'll probably lose my job. If I lose my job, it's going to mess up my relationships, and I don't know what I'm going to do. I'm just going to have to just give up and move, and there they are. The brain is getting anxious. The anxiety is sending signals to the gut. The gut is acting up. And so it's an exaggeration, but you have this conversation with people, and their eyes light up, and they laugh, and they say, oh my gosh, you just described me. How did you know what I was thinking? These kinds of thought processes impact symptoms, but the nice thing is that they can be reversed. They just have to be identified and dialed back and in a structured way, changed to something like, oh, I feel my stomach, something's going on today. Okay, well, I can handle that. End it there, move on, and test out each new step that they take through their day, rather than going way down the block into catastrophizing. So these protocols utilize education, relaxation techniques, so they do a lot of abdominal breathing. Some use visualization and imagery to relax the person. The cognitive restructuring, like I talked about, and even exposure techniques, the type that were pioneered in post-traumatic stress disorder. So identifying those places or those activities that might be most frightening for the patient, and then having them test them out in a safe way. And so this can be quite helpful. So it turns out that both minimal contact, so part online and part in-person visits, can help, as well as standardized CBT, and that over time, even at 6 months, people have benefit. You need to find a therapist that is qualified and that will work with you. And I find that this book by Jeff Lackner, who did a lot of the pioneering studies in this area, is really helpful not only for the patient, but for the therapist as well. It's a really good description of how you use CBT. The last thing I'll talk about is mindfulness-based stress reduction. It's been around since the late 70s. This is also a protocolized 9-session intervention where people learn techniques of meditation, yoga, and a little bit of cognitive restructuring as well in a group setting, and has been shown to increase the patient's sense of the present moment awareness rather than going down the block like I talked about earlier, being where they are with acceptance and with kindness. It also sounds simple but works pretty well. It's been useful for treating pain, depression, anxiety, and post-traumatic stress disorder. It turns out it works well for IBS, reduces specific IBS symptoms, global symptoms, quality of life, and some of the symptom-related anxiety. And these improvements tend to persist for at least 3 to 6 months after the intervention. Where can patients learn about mindfulness-based stress reduction? We have on our UCLA website, the Mindful Awareness Research Center. They don't do MBSR, but they do their own version of it that's quite similar. At UMass, this is where these protocols were developed. They have a Find Provider site on their website where you can look for people who've been trained through their protocols nationally. And there are a number of apps for the phone that patients find really helpful. So when do we use these? Which one do we choose? What will it cost? Which one you choose, well, when to use, we sort of talked about. Those patients where we think a mind-body interaction is important, patients who have a fair amount of anxiety associated with their symptoms and hypervigilance. Which one to choose? This is going to be really based on your patient and what resonates for them, but also who you think is the best provider within your area. If you have a particularly good mindfulness instructor and don't have the other two, you can obviously try to lean your patient towards that. Same with cognitive behavioral therapy or hypnosis. What will it cost? It's going to cost them a fair amount. These interventions usually are not paid for by insurance. If the patient has a diagnosis of anxiety or depression, a psychologist can use that as a billing code, but often these will cost anywhere from $500 to $3,000 for a set therapy, and it's useful for the patient to discuss the cost and the anticipated duration of therapy with a practitioner up front. But we're looking for a long-term benefit. One of the key things in closing is that warm handoff that you have, that the patient feels that you're actually working with someone else to help them get better rather than sending them off and saying goodbye. So with that, I'll close. Thanks.
Lynn,
Thank
can I make a
you.
comment?
Please.
That was a great talk. But I just wanted to say that, we're starting this wellness program in our clinic. And so Suzanne Smith, who's a nurse practitioner, has worked with Kirsten and me for many years, is coming into our clinic to build that more integrative health care. And she's trained in mindfulness. So some of the fellows are starting to do that. It's not quite open yet, but this is something that we're trying to build at UCLA.
That's great. So you had mentioned already how you decide, Kirsten, between cognitive behavioral therapy, mindfulness-based, and hypnotherapy. Do you ever switch with one patient? Do you ever recommend starting with one and then end up switching? And can you do two at the same time?
I don't recommend people do multiple things at once. Often when you have a patient who wants to try everything all at once, it's someone who's not really committing to anything and probably will not get the benefit. But I do sometimes switch. So someone may start with, I can think of a recent patient, started with hypnosis, but it turned out going into that hypnotic induction made her so nervous, it actually exacerbated her symptoms. And so she did better with a cognitive behavioral therapy approach. And I often do combine these therapies with medications as well.
Mm-hmm. So she was very excited about embarking upon this, and she did about a year of various different types. And she did feel that her symptoms improved, especially the anticipatory anxiety about going out. But she felt that as her work got more stressful, her symptoms were coming back, and she feels that it's still impacting her ability to do her job and her ability to have a social life. So at this point, when she comes back, she wants to continue the mindfulness-based stress reduction that she'd been working on, but at this point, she's really open to medication treatment. So to kind of go over the various options, I'm going to invite Lin Chang up to talk about this.
Good morning, everyone. Good. So I'm like Kirsten, and when I take care of patients with functional GI disorders, I use a multidisciplinary approach, and for fellows who have been in my clinic know that I spend a lot of time educating the patient, reassuring them. But when I listen to a patient, I'm always thinking about what's their story, what are the factors that triggered their symptoms, what do I think the pathophysiology, what's the mechanisms that are driving their symptoms, and what's their coping management style and their expectations to try to build a better relationship and I think a more successful treatment, although it is time consuming. So I'm going to talk about pharmacotherapy. So as we mentioned, there are two main subtypes, the epigastric pain syndrome and the postprandial distress syndrome. And some of the treatments really honestly could be used for both, especially if they have overlap. But I'm going to try to give you the data for each type. So if you look at the bottom of the pyramid, we have mild patients, which, there's many more of those. And those patients have, their symptoms don't really impact their quality of life, unlike this patient where she's more moderate. Probably not quite severe, but getting there. And so you make a positive diagnosis, diet, lifestyle advice, reassurance. If there's some over-the-counter remedies, you can give them. And then, of course, building the patient-physician relationship. For postprandial distress, a lot of times they have nausea, so you can use some antiemetics or anti-nausea medications. Prokinetics are thought to be a potential treatment for them, although we don't really have that many available, but I'll talk about that in a second. And then there's some data, although it's small amount of data, for buspirone and mirtazapine. And then I'll get to epigastric pain syndrome afterwards. The thing to remember is, what do you think the pathophysiology of functional dyspepsia is? So there's multiple mechanisms, and some patients may have one or the other. We don't always test for them. But remember that about 40% of functional dyspepsia patients have decreased gastric accommodation. That means their fundus doesn't accommodate when they eat or drink, and if you don't accommodate the food and the water, then the pressure will increase, and the patient's symptoms will get triggered earlier. Patients also have visceral hypersensitivity, like most functional gastrointestinal disorders. There's about 25 to 50% that have delayed gastric emptying. And then there's another mechanism, there's H. pylori, but then that's considered not functional dyspepsia really anymore. And then there's duodenal hyperacidity, but that one hasn't been studied as much. For the gastric accommodation, the symptoms that have been linked to that, decreased gastric accommodation, is early satiety and weight loss. Okay, so this is the data for buspirone. This is a crossover trial, very small. I would consider a pilot. It was done many years ago when it was actually Rome 2 criteria for functional dyspepsia. Buspirone is a 5-HT1 agonist, so it's thought to increase gastric accommodation. So patients were treated for, I think, 4 weeks, and they crossed over, 2-week washout, got the placebo. And what you can see on the left panel, dyspepsia severity score, if you look at the white bar, that is prior to placebo, then with placebo, and then prior to buspirone, and then after buspirone. And you can see with the drug that it decreased their symptom severity. If you look at the individual symptoms, the symptoms that improved with buspirone was postprandial fullness, bloating, and also early satiety, which is what you could have expected. The dose was 10 milligrams TID. I start low dose, then I move up. This is also a weak anti-anxiety agent, which can be beneficial, very well tolerated. The other thing to remember is that a lot of these functional GI patients, particularly functional dyspepsia, have coexistent anxiety, and they have shown that with increased anxiety, it actually worsens gastric accommodation and also can increase visceral sensitivity. So I think targeting anxiety is very helpful. Okay, this is a study on mirtazapine. Again, this is a pilot study. This was done by Jan Tak's group in Belgium. This was for patients with functional dyspepsia and weight loss. And the mirtazapine dose they used was 15 milligrams at bedtime. Mirtazapine has very similar qualities like a tricyclic agent, so it's a serotonin norepinephrine reuptake inhibitor. It's also an antagonist to histamine, 5-HT2, and also 5-HT3. And the 5-HT3 antagonist quality is like ondansetron, and that's why it might be helpful to reduce nausea. Because of the 5-HT2 antagonist aspect, it's thought to work centrally and increase appetite. So the one side effect with this drug is a weight gain. So this woman lost weight, so this could be a potentially good drug for her. It also treats anxiety. It's also good for insomnia. The problem that she will have, that most women have, is that they don't like weight gain, even if they've lost weight. But this is potential. So you can see the data that with mirtazapine, that it reduced symptom severity of dyspepsia, and it also increased body weight. So this would be actually a choice and something that you could recommend in this particular patient. Okay, so let's get to epigastric pain syndrome. So for H. pylori, there's been a lot of studies looking at the eradication and resolution of dyspepsia. You can see the wide range of studies, and in general, it favors that you treat H. pylori if someone has dyspepsia symptoms. But a lot of these studies, the patients weren't really as well characterized as you would like. Some of them are uninvestigated dyspepsia, not so much functional dyspepsia. But this is a consensus group came together looking at H. pylori associated with dyspepsia. So if the patient is Helicobacter positive, then you want to eradicate them. And then you wait some number of months, because a lot of patients will get better just initially, and then they'll still get back their symptoms. But over time, if they don't have symptoms, then you call it H. pylori associated dyspepsia. If they do still have functional dyspepsia symptoms, then they have functional dyspepsia. So with eradication of H. pylori, there is a small but statistically significant benefit of treating H. pylori. I personally even forget about H. pylori because at least in LA we don't see that much of it. But what I would say, and Bill Che has always said this, and I have to agree with him, is that if you treat it and they get better, that's a cure. So it's worth the investigation. Okay, so PPIs, if you look at the different predominant symptoms and look at the efficacy of PPI, it's really in patients who have some reflux-related symptoms or epigastric pain. So if somebody has those symptoms, because functional dyspepsia can be coexistent with GERD, you do want to try a PPI and see if that improved their symptoms. I think if someone has some partial relief or complete relief, great. If they have partial relief, I would continue it, but then you have to target your treatment on their existing symptoms. Okay, so if you look at the treatment response in functional dyspepsia of the different types, you can show that there is a relative risk reduction in the symptoms with prokinetics, H2 blockers, and proton pump inhibitors. The prokinetic studies were mainly in the subgroup of dyspepsia patients who had delayed gastric emptying, which you would expect is the target population. H2 blockers were mainly in patients with epigastric pain, and PPIs were including patients with GERD. So this is an old study on venlafaxine. So venlafaxine is a serotonin and norepinephrine reuptake inhibitor, so it's an SNRI. It also has a very weak dopamine reuptake inhibitor quality. This is a double-blind, placebo-controlled trial. It was a multi-center trial in 160 functional dyspepsia patients, venlafaxine versus placebo. And I'm not exactly sure why they use this dose, but for the first 2 weeks, it was 75 milligrams once a day. Then for 4 weeks, went to 150 milligrams, and then the last 2 weeks was 75 milligrams once a day. And these are still relatively on the lower side of the dose. And basically, they treated the patients for 2 months, but they followed them out for 20 weeks. So what you see here is that there's really no benefit of venlafaxine versus the placebo. So I don't personally think venlafaxine is that helpful for functional dyspepsia or lower GI conditions. There's some evidence that's effective for functional chest pain and functional heartburn, but for the lower GI symptoms, it's really not as helpful. One thing that could have been the case for this drug is that lower doses of venlafaxine, you have more of the serotonin reuptake inhibitor quality. As you go up on the dose, you have more of the norepinephrine reuptake inhibitor. And I personally think that the norepinephrine reuptake inhibitor quality is what really reduces pain, less so for the SSRI quality. This is a randomized controlled trial of sertraline, which is an SSRI, and this was in functional dyspepsia patients. You can see over the time is 50 milligrams. 98 patients were in that group, and the placebo is 95. There were 22% that dropped out. If you look over it in time in the intention to treat analysis, it was not statistically significant. If you look at the per protocol, so that's patients who stayed in the study, they took the placebo or the drug, there was some benefit by 2 months. This is really, I think, the best study. This is the more definitive study. It's a multi-center NIH-funded trial looking at tricyclic agents and SSRIs for functional dyspepsia. What they did is they used placebo, amitriptyline, and escitalopram, so it's SSRI. And they studied the patients. They had an interesting primary endpoint. It was adequate relief in 5 out of 12 weeks, which is a little strange because you usually do at least 50% of the time, but they used 5 weeks or more and basically showed a benefit with the tricyclic agent, which, remember, a tricyclic agent is a serotonin norepinephrine reuptake inhibitor. I think people forget that. It is an SNRI, but it's a little bit dirtier drug because it also is a histamine antagonist and an anticholinergic agent. But there was no benefit with the SSRI. I think what was interesting is they try to break down the types of patients, and it turns out that the tricyclics were more beneficial for the patients with this ulcer-like. That's the characteristic they used when they started this trial some years ago. So it looks like it's better for the epigastric pain syndrome than for the postprandial distress, and it was better in patients with normal gastric emptying, which is what you would expect. Personally, for functional dyspepsia, I probably would not use amitriptyline. I would use disipramine or nortriptyline with less anticholinergic effect, trying not to delay gastric emptying. If you think that's a pathophysiologic mechanism, that could drive some of their symptoms. So I gave you a table to end with for all the different treatments. So for PPIs, they have been shown to be superior over placebo, definitely used in patients with more epigastric pain or patients who you think have coexistent GERD. For H. pylori treatment, it's a small but statistically significant benefit over placebo. Metoclopropamide, there's no controlled trials. Domperidone, there is some global improvement without improvement in gastric emptying time, interestingly. So I think it just reduces the nausea and some of those symptoms. Low-dose tricyclic agent has been shown, the multi-center randomized control trial, to have benefit over placebo. SSRIs have shown lack of efficacy. Buspirone can improve your symptoms. It can increase fundic accommodation, which was shown in a study. Herbal therapy, there's some evidence that this is effective. I haven't found that it's that great, but it could be that I just take care of more severe patients. As Kirsten said, psychological and behavioral therapies have shown benefit, and I definitely think that should be part of your treatment strategy, definitely to reduce anxiety. And 5-HT4 agonists, Digasteride normalized gastric emptying, didn't show that much benefit for functional dyspepsia. There's some evidence in an abstract that was presented last year at the UEGW that prucalopride, which is a 5-HT4 agonist that we don't have available here yet, but we use for chronic constipation, you can get it in Canada, that it can enhance gastric emptying and have benefit in patients with gastroparesis. For that subtype of functional dyspepsia with delayed gastric emptying, that's potentially a treatment. Thank you very much for your time.
Thank you. So in this patient, Lynn, you mentioned several different treatment options. Mirtazapine was presented to her, but she did not want to risk gaining any weight. So with that in mind, what would you recommend at this point for this patient?
I would probably use buspirone. I would try it. I don't think it's a great drug, but I do think that if particularly patients who have a lot of side effects to drugs, and if it gives her some weak anti-anxiety effect, that would be helpful. So I would probably try that just because I think she has most postprandial distress. I also probably, if she didn't want to do that or if that didn't work, then I would use a low-dose tricyclic and I would use one that has less anticholinergic effect.
Okay. And for the dosing of the buspirone, how would you start that, and would you titrate up the dose?
Yeah, I've done it a couple different ways. It comes as 5 milligrams and 10 milligrams, but you're supposed to start at a lower dose. You're not supposed to start at 10 TID. So I usually start at, I either give them 15 milligram tablets, and I tell them to break it in half and do 7.5 BID, and then after a week or two go up to, then add 15 and then 7.5, and then go to 15 twice a day. Or you could do 5 milligrams, probably TID, and then what you do is you gradually go up. So if you take it 3 times, then you do 10 milligrams, 5, 5, then you do 10, 10, 5, and then you do 10 3 times a day.
Okay, good, thank you. So she ended up being started on the low-dose tricyclic disipramine, 10 milligrams, and then she was increased slowly to a total of 40 milligrams. And just to stick with the dosing, if you're starting someone on a tricyclic, do you usually start at 10 milligrams, 25 milligrams? Does it depend on the person, the diagnosis?
Well, Doug Drossman and I differ on this, and we will forever differ on it as good friends as we are. I usually start at 10 milligrams, and then I go up 10 milligrams, not more than 10 milligrams per week. If someone has an adverse, like a side effects, that maybe they're a little drowsy, then you usually wait 2 weeks, because it takes about 2 weeks to get over to kind of adjust to that. He starts at 25 milligrams because his thought is if you start too low and there's no benefit, then they want to get off of it. But if you do that, then you have to make sure that you can manage any side effect. So in a lot of times for a guy or someone who's a larger, I would probably start them on 25, especially if they don't report adverse events to other drugs, then I will do that. And then I'll go to 25, sometimes 37.5 or 50. But otherwise I go 10, 20, 30, and then I try to use the lowest, most effective dose because you have to counter the side effects. And then it's really important to tell them is that that it may take 4 to 8 weeks to have a beneficial effect, and you have to get at a pretty good dose. And the other thing to remember is that low doses of tricyclics don't actually have mood-altering effects. So you really want behavioral therapy, or you want to address their anxiety or depression a different route.
So she ended up doing that. So in addition to staying on the disipramine 40 milligrams for 6 months, she continued to work with a cognitive behavioral therapist on addressing her anxiety and also with a registered dietitian. And then after about 6 months, she was able to slowly taper off the disipramine. And I know many of our patients, when we bring up starting a central acting medication, they're concerned that this is just going to be an indefinite treatment. Is it an appropriate expectation for patients to be on these for a set period of time with the goal to get them off?
I think that's a really good point, and I do think that they get scared about that. I think it depends, right? So I think if a patient is doing well, and if they're doing the other diet, lifestyle, behavioral modifications, yeah, you'd eventually want to get them off pharmacotherapy, right? I mean, that's what would really be the goal. If they're doing that and they're getting better, I would definitely taper off whatever agent they're on. If they're not really doing that, or it's not good enough, it's not enough, then sometimes you have to keep them on. I mean, one thing that you usually you're hoping for, and I think there's some evidence of this, is there's a neuroplasticity effect, so you're hoping that they have some normalization. I think the mistake that patients make that when they feel better, they want to come off it really fast. And I think what's really important is that they have to be doing well for, some people say 6 months, I would say almost a year, and then I would taper off.
I would reiterate that duration, because patients really do want to start coming off too quickly, and neuroplasticity takes some time. So I usually give them up front, when you're feeling better, we want to wait for about a year, knowing that some patients will not wait a year, and that's okay, but so that they have that expectation. And if we feel like, yeah, they're doing great at 6 months, we can try tapering them off, that's a possibility. But I find that it's better to wait longer so that they don't relapse, and then you get them back on.
Yeah, I agree.
Thank you. So our second case is a 45-year-old female who presents with chronic constipation. She says she's had constipation her entire life. She was told by her mom that she needed suppositories as a young child. As a teenager, she had no idea that it wasn't, quote, normal to have a bowel movement every 3 to 4 days. In her 20s, she just started to drink lots of coffee. But over the last 10 years, she realized that even 3 to 4 cups of coffee every morning was not enough to really work for her. She describes that she has one bowel movement every 3 to 4 days, and it is a Bristol stool chart 1 to 2. And I'll pause for 1 second, because do you find that in the clinic setting, not in the research setting, that it's helpful to actually bring this picture up and ask patients to point out what form their stool is, and if so, why?
You know, I have, if everyone knows that, who have been with me in clinic, I have a little card in my pocket, and for the longest time I never used it. But I was with a because I always thought, okay, I know they describe their stool form to me, I can tell what they have. But I had a patient who went on and on and on, and I couldn't figure out what she had, so I pulled out the card, and she said, I have that. And I'm like, okay, I'm using this card every time. Save some time. I think the problem with constipation is that the patients are usually on a treatment, so I don't know what their virgin stool is, without medications. That's a little bit of the problem. So you're assuming that they have hard stool. So I try to get a history of the 6 signs and symptoms of constipation, without medication.
So when describing her bowel movement, she states that she strains usually about 5 or 10 minutes with most of her evacuations. She occasionally has anal pain, especially with the hard bowel movements, and she describes a sense of incomplete evacuation about 75% of the time. She does not ever need to use digital maneuvers in order to have a bowel movement, but she does state that she occasionally has blood on the toilet paper when she wipes. She's been using fiber gummies and Senecot, sometimes daily, sometimes every other day, with only minimal improvement. She came today after all these years because she's very anxious and fearful that every decade things have been getting worse, and as she continues to age, it's going to spiral out of control. She also states that she has some bloating and occasional mild abdominal discomfort that is partially relieved with defecation. She describes a number of somatic symptoms. She says she gets headaches, sometimes she has breathlessness, dizziness, lethargy, a lot of fatigue. She sleeps poorly, and she scores on the hospital anxiety and depression scale a 13, so elevated for anxiety, and 5 for depression. And her patient health questionnaire score for somatic symptoms, so this is a list of 12 somatic symptoms, was elevated. So a lot of our patients come in and we really focus on the GI symptoms, but they are always mentioning brain fog or fatigue, or they get headaches. And so my question is do you find that it's helpful, maybe Kirsten, I'll ask you to ask about these, and does that affect treatment at all?
Yeah, I think asking about other body symptoms sort of helps me understand what's going on. Is this isolated idiopathic constipation? Is this irritable bowel syndrome with anxiety, multiple somatic symptoms? That probably I'm going to go more towards something that has some central effects. Whereas someone who just has constipation, and I think I can manage that with just a laxative, I'm going to go that route and not get them involved with mindfulness or CBT. Yeah.
So her physical exam is mostly notable for on the rectal exam, she did not have any evidence of pelvic floor dyssynergia. And I know a lot of our fellows and a lot of us don't necessarily like to do rectal exams in the office. And my question is, one is, how sensitive is a rectal exam for dyssynergic defecation? And should we start with that as opposed to just jumping directly to an anorectal manometry study? Or is it appropriate in patients who have not had a response to laxatives to basically not do the rectal exam and just jump to the manometry study?
I think it's always good to do a rectal exam.
Absolutely.
Because, if you're going to wait and they're going to try some other treatment, you have to bring it back and do that, and you don't necessarily want to have to bring them back to do a rectal exam. You're right there, so.
That's true.
Yes.
So I guess I could rephrase this since we all do the rectal exam. If you do a rectal exam and it does not show that you have dyssynergic defecation, is that enough, or do you feel that the rectal exams are not that sensitive for this particular question?
If you're doing it appropriately, and sometimes people need a little coaching, and it's completely normal when they bear down, then there's a high negative predictive value. They do not have it. So you would not necessarily send them to anorectal manometry to look for dyspnea defecation. If it's positive, it doesn't mean that they have it. But you have to send them for anorectal manometry to see if they really have it or not.
Great.
Because
So
you can't tell by symptoms.
Great, that was thank you. So what would you say the diagnosis is in this patient? Is this chronic, is this functional constipation, or is this irritable bowel syndrome?
Well, it sounds like she also has bloating and pain, anxiety.
Anxiety, really minimal bloating and pain, but yes,
Okay.
definitely anxiety.
So if she doesn't meet the criteria for irritable bowel syndrome, then it would be functional
Then it would be
constipation.
functional
But it is, I think it's a very difficult thing to sort of, to navigate. Sometimes it's very obvious. This person has constipation, they don't have a lot of pain, they don't have a lot of distress, they just are constipated. And sometimes it's very clear that pain is their predominant. But there's all those people in the middle that I really have difficulty with.
Yeah, I mean, the one thing that Rome 4 did is that they recognize, based on studies, that it's a spectrum, and you should think of it as a spectrum, right? So you have patients with more predominant pain with constipation, that's IBS with constipation. The other spectrum is patients who really don't have pain, and that's functional constipation. But there are people in between, and they could shift.
So she can definitely shift, because right now she's not necessarily claiming that abdominal pain and bloating are her overwhelming symptoms, but she definitely has them, and perhaps at different points she could vary along this scale. So for her, one of the things we started with was a diet recall. And my first question for Nancee is, when you're trying to assess a patient's diet, is it better to ask for a specific 24-hour diet recall, or to say, what do you have for breakfast normally? What do you have for lunch?
I think that if you use the words breakfast, lunch, and dinner, you can actually cause problems, because not everyone eats on that type of meal regularity. So instead, saying things like, what time is the first meal of the day, and what does that meal look like typically, will give you a lot more information. And you can actually do a diet recall pretty quickly using that tactic. It can also help you to see how much variety they get in a week period, which is what I like to see. So just doing a strict 24-hour may not give you the full spectrum of what they like to eat. So I would probably ask it in a little bit more of a vague and generic way.
Thank you. So for her, she had the 24-hour diet recall, though she says she doesn't really vary that much in her diet. So she has Rice Krispies with lactate milk and bananas for breakfast, a wheat sandwich with turkey, lettuce, tomato, and then dinner she usually has some sort of protein, chicken last night, with broccoli or another vegetable, and mashed potatoes. And she says she drinks roughly about 1 liter of fluid a day, including coffee, juice, and tea. Another question we get a lot from patients is, how much water do I need to be drinking every day?
So the kind of basic answer for that is 35 milliliters per kilogram of body weight. So the whole idea of, you need to have 8 cups of fluid a day isn't really true. It's really based on the individual body. You can use that as a rough estimate. Most people just are simply not taking in enough fluid, as our patient is not.
Do you have any other comments on her diet, just at a quick glance?
So she's eating an incredibly soluble fiber diet, and as we're going to learn soon in my lecture, soluble fiber is more indicated for diarrhea, so she's not really eating a very fiber-appropriate diet at this point in time.
So at this point, when we talk to her, she, like many of our patients, at first clinic appointment does not want to start on a medication, but she's very interested in looking at her diet, and she would be willing to do some type of fiber supplement or maybe even change her diet appropriately. And we get this a lot. We all recommend fiber, and sometimes we have our specific one that we recommend. But I wanted to ask Nancee to come up and help us figure out, for constipation and diarrhea, which fiber we should be using.
All right, thank you, Lynn. So fiber, it's a pretty confusing topic, both for dietitians as well as for doctors. So I'm hoping that with my lecture today, I'll help to explain the different characteristics that make up a fiber and help it to work, how different fibers work and what they work for, and then in the end give you how you might be able to recommend fiber to your patients and at what dosing. So oftentimes we just tell patients, add more fiber to your diet. And this can be a very confusing thing to say because when our patients go to the grocery store, this is what they are met with. And I don't know about you, if I was the patient and I walked into that fiber aisle in the grocery store and I saw all of these supplements, I would have no idea what to buy if I wasn't instructed. So it's really important that we don't just tell our patient to add in more fiber, that we actually give them very specific instructions about which fiber we think would be most beneficial for them. So how do we go about doing that? If we understand the fiber characteristics, we can often make good decisions and good choices about which fiber to recommend to our patient. So when it comes to the different characteristics of fiber that we want to consider, the main three are solubility, fermentability, and viscosity. I always like to point out that, of course, there are other things about fiber that we love and that we need to pay attention to, such as the effects on the gut microbiome, as well as the creation of what we call short-chain fatty acids or metabolites. But unfortunately, we don't have time in our lecture day to discuss those, so we're just going to focus on the top three. So solubility is probably the one that people are most familiar with. We hear the words soluble and insoluble all the time. But if you're like me, we didn't really get a lot of training on what those terms meant. I know I only got about 2 days of my dietetic education where we actually talked about fiber. So solubility is that it is capable of being dissolved in fluids. You can think of solubility and bulking capacity or the ability to hold water as being synonymous. So when you think of the word soluble, you can use the S in soluble to remind you of the S in sponge. So sponge and solubility go together. And so we think of something that is soluble as being able to bulk, being able to hold fluid, staying pliable. When we think of insoluble, it's the exact opposite. So this is the inability to hold water, which usually means it's going to play a role in movement and how quickly things move through the colon. And this is especially true if we pay attention to the coarseness or smoothness of the fiber. So what we know is that when we have a coarse fiber, it actually does what we call mechanical irritation, where it actually irritates the gut lining of the colon and forces it to secrete fluid and mucus, and it also encourages movement. So this is how insoluble fiber, such as wheat bran, can actually help the stool to stay soft and bulked and help it to move through the system. So along with solubility, we need to think about coarseness versus smoothness. Smooth is more indicated for diarrhea. It's also what helps to lower cholesterol in our patients. So as a dietitian, I would be remiss if I didn't talk about food as well as supplements. So when we think about soluble fiber-rich foods, we can think about the fleshy parts of our fruits and our vegetables. And the example I like to give to my patients is that they can visualize an apple versus applesauce. So all of us can imagine that we've got this beautiful, ripe, crisp apple, and when we bite into it and we tear through that outer flesh, it makes a really loud crunching noise. And once we get into that softer, mealy, meaty, fleshy part, it makes more of a squishy, slurpy type of noise. That means we've gotten to the soluble fiber and broken through the insoluble fiber. So this is the reason why we recommend applesauce and not apples if we're going for more of a soluble fiber type of diet. These are also the foods that are considered quote-unquote low residue, right? So these are the foods we might recommend for a small bowel obstruction. If we are going to recommend a supplement, the types of supplements that we might recommend include things like wheat dextrin, psyllium husk, guar gum, and you'll notice that I put methyl cellulose and polycarbophil with question marks. That's because these are actually insoluble fibers that have been mechanically altered to be soluble, so they can kind of work in both camps. When we look at insoluble fiber, again, this is the reverse of what we just talked about. These are the tough outer parts of our fruits and vegetables, nuts and seeds, beans, legumes. And so you can think of like celery and kale is a good example. And of course, we've got our fiber supplements that go along with these as well, including things like cellulose and the two I mentioned previously. So viscosity is the next characteristic that we like to focus on. And viscosity we often think of as the ability to form a gel. But that's not really what I think the most important aspect of viscosity is. I think it's the fact that there's a resistance to flow. So if we think of solubility as being the ability to hold water, we think of viscosity as slowing transit time. So it's the resisting of movement. And so when we think about high viscous fiber supplements, they could be things like psyllium husk and guar gum. We can also use food forms like barley and oats. With low viscosity, we would think of things like wheat dextrin, wheat bran, polydextrose, which are those fiber gummies, and inulin. And we've seen from the research that the water content of stool is inversely proportional to stool viscosity. So you can think of how rapidly a substrate transits the large bowel is a function of viscosity. So whenever you think high viscosity, that means the laxation has dropped, an inverse relationship. So if we're really interested in helping our patients to move their bowels, we want to think about lowering the viscosity. The final characteristic that we look for with our fiber supplements is fermentability. So fermentability is the breakdown of something by bacteria, yeast, or other microorganisms. And this has the same issue that viscosity has. They're inversely related. So as fermentability goes up, the ability to create laxation goes down. And this makes sense. In order to have good laxation, fiber has to be present in the bowel. And if it's fermented away, it doesn't exist in the colon anymore. And this isn't going to help with that mechanical irritation that we are describing. So high fermentability foods, we're going to talk about actually in our last case, are our FODMAPs, right? So our fructans and our galacto-oligosaccharide-rich foods. There are several supplements that are also considered highly fermentable, things like wheat dextrin, which is why we don't want to recommend wheat dextrin for our constipated patients, inulin, polydextrose, those fiber gummies again, and guar gum. Low fermentability would be things like wheat bran, as well as flax seeds and oats, and things like the insoluble fibers, right? So cellulose, methylcellulose, and then psyllium husk is a unique one that is soluble but also works in this category. So we've gone through the different characteristics, but we haven't really talked about how do you now take all of this information and pull it together and actually give your patient something to go to the grocery store and pick up. So here are my fiber rules. You always start with solubility. And so when we think about soluble, think about bulking. You're holding water, which means that it will probably help your diarrhea patients. Insoluble adds weight and mechanical irritation, which is going to help with movement, and so this is beneficial for our constipated patients. When we think about viscosity and fermentability, remember that it's an inverse relationship. So the higher the viscosity, the higher the fermentability, the lower the ability to create laxation. We also want to pay attention to whether or not the fiber is coarse or fine, as I mentioned in the beginning of this presentation, and then whether or not we want to be recommending supplements, foods, or some combination. So before I give you my cheat sheets, let's just remind ourselves of what helps to create stool regularity. So stool regularity needs to have both mechanical irritation and water holding capacity. So in order to create good mechanical irritation, fiber has to be present in the stool, which means we want fermentation to be low. In order to have good water holding capacity, the important aspect is solubility. So you'll notice that both viscous and non-viscous fibers, as long as they are soluble, can be helpful from a water holding capacity standpoint. The big difference with viscosity is how quickly it will transit. So that's really where we can pay attention to viscosity. Also, we have to remember the two mechanisms that help to create a laxative effect. So the first one is what we call the viscoelastic effect, right? This is what helps to keep the stool nice and soft. We also want to consider what we call the plastic effect, which is that mechanical irritation. So I'm hopeful that with this knowledge, this next cheat sheet will be very helpful for you in your practice. So what I always like to think about when I am looking at a patient and I'm listening to their story, what I'm thinking about is, do they need a soluble or an insoluble fiber? One thing that we know is that if there is mechanical irritation, so meaning we have a coarse fiber, whether it is soluble or insoluble, that can actually increase visceral hypersensitivity. So we never want to give that to a patient who has IBS. So wheat bran is not indicated for an IBS patient. That's why you'll notice at the bottom where it says insoluble fiber, it's really just for chronic idiopathic constipation patients. When I use soluble, high viscosity, high fermentability is when a patient has something like microscopic colitis where the frequency is just too much. I'd probably start with something more like a wheat dextrin, just because that tends to work well. But I found for some of my patients where a soluble, low viscosity, high fermentability fiber does not keep the frequency down, they really need that added viscosity to help. The issue, of course, is that things like guar gum are highly, highly fermentable, and so it may cause some increased gas for those patients. So sometimes using a combined therapy of guar gum and wheat dextrin or guar gum and polydextrose can be really helpful for those patients. But when in doubt, go for psyllium husk. So psyllium husk is my favorite fiber to work with. The reason why I like it is that it doesn't care which side of the Bristol stool form scale chart you're on. It will move you towards the middle, towards type 4. And this is because it has a very unique combination. It is soluble and highly viscous, which means that it can hold water and form a gel. But then because it's low fermentability, it doesn't get stuck in terms of laxation because all of that fiber is still in the colon. And if you need it to be of a coarser variety, it can help more constipated patients. If you choose a more smooth, fine variety, it'll help your diarrhea predominant patients. And it's actually the only fiber that has been given any sort of grade with the American College of Gastroenterology when it comes to constipation. So psyllium husk is a nice one to start with. In case you would like to use food forms, I also give you a chart with food forms, which would hopefully be helpful. But of course, you may recommend a supplement, and so I wanted to make it really, really easy for you. These are the most commonly prescribed supplements, and these are the different ways that in my practice I've chosen to use them. So hopefully this chart will be very useful as you go into your clinic setting and try and practice some of the things that we talked about today. But of course, fiber isn't the answer to everything. So there's some cautionary tales that we have to tell about fiber. For instance, some medications are affected by soluble viscous fibers. This makes sense. They would get bound up in the fiber supplement. So if you have patients who are taking thyroid medication, cholesterol-lowering medication, if they're on fat-soluble vitamins, iron, zinc, calcium vitamins, they want to make sure that they separate their oral prescription by at least 2 hours from their fiber supplement, so make sure that you let your patient know that. As I mentioned before, wheat dextrin, not great for constipation. It's going to actually create a lot of problems, and you're going to have a very angry, constipated patient on your hands if you tell them to go to the store and buy wheat dextrin. So be really careful about that one. Also, hydration is key, right? So as we mentioned before, a lot of our patients are simply not well hydrated. If they're not well hydrated, we expect the stool to be harder, firmer, and not as easy to get out. And this is especially true in our elderly population, so making sure that they're adequately hydrated first before you add in a fiber supplement would be very helpful. The other thing to be careful about is when you add in fiber, you need to add in water to compensate for the extra fiber. So you need to up their water intake anyways when you give them a fiber supplement. And then, of course, you want to be careful about how you dose it. So start really slow. Any fiber supplement, even the non-fermenting ones, if you bring them in too quickly, are going to cause GI symptoms. So I'm a big fan of start with 1 teaspoon, increase it every 2 to 3 days as the patient needs up to the max dose. You can also use the adage that by the end of the first week of taking a new fiber supplement, you want them at a 5-gram dose. So if you're using psyllium husk, that would be 1 tablespoon by the first week, and then 2 tablespoons, which is the max dose by the second week. Another thing to be aware of is that as much as I love fiber, it's not indicated for every single bowel disorder. So what we've seen is that about 50% of patients who are refractory to supplementary fiber probably have some sort of transit issue. And so we don't recommend fiber supplements for our slow transit constipation and our dysenergic defecation patients. You've got to work with those disorders first before you would ever consider bringing in a fiber supplement. Thank you.
Thank you. So we'll all be using psyllium husk. So she did not start with psyllium husk. She started with benefiber, and as Nancee predicted, came back with a lot of gas pain and bloating, and was quite unhappy. So she was switched to psyllium husk, which she liked better, but she still felt was not completely solving her problem of constipation. So she's coming back now, and she says that she has worked with the registered dietitian, her fiber intake is appropriate, she's on the right supplement, but she is not better. So she's open to trying medication. So just, again, the only thing that she has been on so far is fiber. So when you're approaching a patient with functional constipation who's only tried fiber, what is the first thing that you would start with if she's open for any type of medication, over the counter or prescription?
So often I would start with an osmotic laxative, something like magnesium or Miralax, polyethylene glycol.
So she was started on magnesium citrate. And as actually this was brought up with a fellow and me in clinic last week, there's different types of magnesium. So magnesium citrate, magnesium oxide, magnesium glycinate, Nancee, which one should we pick and why?
So the big thing is you want to make sure you do not pick magnesium glycinate, okay? So magnesium glycinate is highly absorbable, and you're trying to choose something that is not highly absorbable because you want it to actually make it to the large intestine. So you can go with citrate or oxide. Citrate, if your patient also has some reflux, may actually agitate those symptoms a little bit, so that's when I would go towards an oxide. Otherwise, citrate is probably my favorite.
So she was put on mag citrate and increased. She didn't really feel that there was a significant improvement, and she would keep forgetting to take it. So she agreed to switch to Miralax. Even with the Miralax 17.5 grams twice a day, she came back saying she hates Miralax. It made her symptoms worse. She looked 6 months pregnant. She felt awful. She just did not like it. So what is next? So to discuss some other options for functional constipation, I'm going to invite Lin Chang up again.
Thanks, Lynn. Okay, so I just summarized in this table the American College of Gastro 2014 recommendations for chronic idiopathic constipation, which is a term I think it really started with pharmaceutical industry, even though by Rome we call it functional constipation. It's really the same thing. So you can see the drug class, the main statement that ACG made in this task force, the recommendation, and the quality of evidence. So the quality of evidence really varies from low to high. If you have a more recent trial, there are metrics for quality, and so these companies will follow them, so they're usually going to be high, but old studies are usually of lower quality. The recommendation being strong means that they feel that the recommendation would apply to most patients in the circumstances, and that if you had any further evidence, it's unlikely to change what their statement and recommendation is. So for fiber, it does show that it can increase stool frequency in chronic idiopathic constipation, help ease of stool passage. Osmotic laxatives like PEG or lactulose are also effective. Lactulose, of course, is highly fermentable, so it tends to give people gas. Bloating. Stimulant laxatives are actually useful, and in some patients, we don't really go. That was kind of this old belief that it causes more damage to your colon. Hasn't really been shown to be the case. I will say that bisacodyl, which has been shown in a high-quality randomized controlled trial to help chronic constipation. In a 4-week trial, it's the most commonly used rescue medication in a clinical trial, and I do think that it usually works with some cramping because it's a stimulant laxative. I just don't think it's a good one to use every day because this is one medication that you find patients will keep upping the dose. But I think it's a great rescue medication. Also, pro-secretory agents like linaclotide and lubiprostone have been shown to be effective, and I'll show you some of the data. And then there's a 5-HT4 agonist called prucalopride. Is more effective than placebo, improving symptoms with chronic idiopathic constipation. Bennett, you're going to be shocked to hear something I'm going to tell you. I got an email this past week from a company that told me they're going to relaunch Tigastrod next year. And Tigastrod, for all the young people in the audience who don't know this, it's a partial 5-HT4 agonist that was FDA approved some years ago for chronic idiopathic constipation, IBS with constipation. But in 1 out of 1,000 people, it caused cardiovascular events, although I think most of them were over 55 and had cardiovascular disease. I'll see how successful they are, but it's if you remember that commercial where everyone lifted up their shirt to show how their bloating's gone. That's Tigastrod. Okay, so this is a treatment algorithm. There's different treatment algorithms. This is the one for functional constipation. The reason why psychological factors are the first part is because Doug Drossman is our president of the Rome Foundation, where we developed all these algorithms and wanted to kind of get that out of the way to determine if someone has psychosocial factors that you want to treat, then that's a different algorithm. But once you're going to treat the GI symptoms, you get the constipation level. And you think of whether it's mild, moderate, or severe. For mild, as we talked about, fiber supplementation is a good option, osmotic laxatives as well. If it's effective, treatment's complete. If it partially relieves their symptoms or it's not effective, then you got to start thinking about other causes. One of the main causes you would think about is dyssynergic defecation, which we talked about. But then you start thinking about more of these prescription remedies, like these pro-secretory agents. You might consider a prokinetic agent, behavioral therapy, if you felt that that would be helpful in the particular patient. And then if they have a defecatory disorder, of course, you want to treat that, because studies show that if someone has dyssynergic defecation and you just keep giving them laxatives or constipation medication, only about 10 to 20% will get better. So you really have to treat the underlying mechanism. Okay, so this is the data on polyethylene glycols, a little bit of a different endpoint done by Jack DiPalma, and it shows the intention to treat population as well as just in the elderly who tend to have more constipation. And the bottom line in this study shows that polyethylene glycol can increase bowel movements, it can soften stool, and it's effective, but it doesn't necessarily improve pain in an IBS with constipation study. So if you're not really trying to treat pain, you're just trying to treat constipation, or if they have IBS, constipation, but very mild pain, you can try this. Once you get their bowels moving, is their discomfort and pain better? Then we have our intestinal chloride channels, where we have 3 medications. So on the right side, you see the ClC2 chloride channel. That's a secondary channel. That is the channel by which lubiprostone works. The CFTR, which is our main chloride channel on the left, is where linaclotide and plecanatide work. They all increase chloride secretion into the lumen. The sodium will follow with the osmotic balance, and then water will also follow as well. And that's where you soften stool, move transit, and move the stool through. This is a phase 3 data from 2 phase 3 trials where it showed the primary endpoint was statistically significant and met by increasing spontaneous bowel movements. And you saw that with lubiprostone versus placebo. This is the chronic idiopathic constipation phase 3 trials for linaclotide, and they tried the 2 doses that are available, 145 and 290 micrograms versus placebo. And basically what you see is they're pretty comparable. So it was only FDA approved at 145 micrograms per day. Some patients try to push up to 290. In this trial, it didn't show as much benefit to do that. And then the new agent is plecanatide. It's very similar to linaclotide. I won't go in the details of the little differences, but they both work by increasing chloride secretion through the CFTR channel. There were 2 doses that were tried, 3 milligrams and 6 milligrams versus placebo, and what you can see from this study is that there was really no difference between the 3 and 6 milligram. So when the FDA approved it a year ago, it was approved at 3 milligrams once a day. So you have linaclotide that's also once a day and plecanatide that's once a day. They do see in plecanatide studies that there's less diarrhea than you see with linaclotide. Okay, so I summarize these pro-secretory agents, whether you use it for IBS with constipation and chronic idiopathic constipation. For lubiprostone, there's 2 doses. There's 8 micrograms BID with meals because it can cause nausea, and then you use that for IBS with constipation. The reason why they studied the lower dose is because IBS patients tend to report side effects, and so they want to use a lower dose. By their phase 2 dose ranging trials, it looked like it would work, less side effects than the higher dose, but you can certainly use a higher dose. For chronic idiopathic constipation, they pushed up the dose, used 24 micrograms BID. For linaclotide, it's reverse. The lower dose is for chronic idiopathic constipation, the higher dose is for IBS with constipation. And plecanatide, it's for both IBS-C and chronic idiopathic constipation, it's 3 milligrams. So plecanatide was first FDA approved for chronic idiopathic constipation, and it has just been recently approved for IBS with constipation at the same dose. So this is what I would say. I think I would honestly use whichever dose you want to use, depending on the patient's symptoms. Use their lower dose if they're moving their bowels, and if they're really, go once every 10 days or something, you want to use a higher dose. But you can start lower and increase it. The only time that you might be important of what you're associating the prescription is, because just by insurance coverage, is whatever dose you're using, make sure you use the appropriate chronic idiopathic constipation or IBS-C that's affiliated with that dose. Okay, and so the last is the 5-HT4 agonist. So the 5-HT4 agonist has a prokinetic effect or promotility effect. It's going to cause contraction through acetylcholine, and then you're going to have relaxation distally through nitric oxide and VIP, and then you're going to cause peristalsis. So as I said, we had Tigasterod in the past that was withdrawn many years ago. But we have now a pure 5-HT4 agonist. So this is not partial. This is a pure agonist, and this has been shown in many studies to improve chronic idiopathic constipation. It's approved in most countries in the world except the United States. There's a plan to try to get it approved in 2019, maybe 2020. But this medication has not been shown to be associated with cardiovascular events. The way this drug works, it doesn't work through this HERG channel, which is where they think some of these partial 5-HT4 and some 5-HT3 antagonists, drugs like Tigasterod, cisapride, that's how it causes cardiotoxicity. But this drug doesn't do that. So hopefully this will be available at some time. It's here in the United States. It's given as 1 milligram or 2 milligram once a day. I typically just use the 2 milligram dose. So just the treatment approach from a practical sense, for mild, I would use diet and fiber, and I didn't realize how complicated fiber was, so I'm glad I have Nancee, and then I don't have to think about all that type of stuff. For mild or moderate, you want to use the osmotic laxative. I would use lubiprostone. I don't think it's as strong as linaclotide, so I use it tends to be if their constipation is a little more mild to moderate, not so severe. If it's an elderly patient who can't take the chance of having diarrhea, loose stools, and make it to the bathroom in time, and it's been around for a long time, so they usually feel more comfortable with it. And then for moderate severe, I would use linaclotide, which I think is the best agent, particularly to reduce pain if you have IBS with constipation. Plecanatide, I do think it's more comparable to the 145 microgram dose of linaclotide. You can use a stimulant laxative and prucalipide. And I always try single agent, but sometimes I use combination rather than trying to keep upping one dose or one medication. Bisacodyl, I think it's a great rescue medication, and if patients are at all refractory to traditional treatment, please try to remember about ruling out dyssynergic defecation. So thank you.
Thank you. So due to the fact that she was having some pain and bloating, she was started on linaclotide. She was started on the 290 dose, but unfortunately she developed diarrhea. And we advise our patients to always take this at least 30 minutes before breakfast. My question is, does it matter what they eat?
Yeah, I think the whole reason why they try use it in phase 3 trials is that that's your best chance of having a bowel movement in the morning when your colon starts becoming activated after being quiescent. And then the meal, because of the gastrocolonic response, some people think that, why don't you take it and then eat bacon and eggs, and then the higher chance of a bowel movement. But I don't think you have to take it at the time.
You don't have to take it before breakfast.
No, that's the data.
Right.
Some patients just like to take medication at night. Their bowels don't respond as fast when they have constipation. They like to take the Miralax, they like to take the medication at night, and then they go in the morning. Because if they take it in the morning and it takes a while to work, then they say, well, I have to go to work or go to school. So you just adjust it for the patient.
So she was dropped down to the 145 of linaclotide, and then as you've alluded to, Lynn, we ended up adding Miralax at nighttime, 1 dose in addition to her psyllium husk. Now, as Kirsten had brought up earlier, she does have a large component of anxiety. A lot of the somatic symptoms were really the main drivers of her negative impact of her quality of life. She was started on sertraline, 25 milligrams. And when we look at SSRIs, we have a lot of different options. In patients with constipation, do you avoid paroxetine, or is there a specific SSRI that you like to use in constipation?
I wouldn't pick paroxetine just because of its increased association with constipation. But if somebody comes in already on SSRI that's working well, rather than suggesting they change, I'll just deal with the one that they're on. But probably as a preference, I would probably go with citalopram or something, else.
Less likely to cause constipation. And I'm just going to move to our third and last case. This is a 38-year-old man who is presenting with abdominal pain, bloating, weight gain, and diarrhea for the last year. He was diagnosed with cryptosporidium in May 2016, and he says since then everything has gone haywire in his body. The bloating's constant, it's life-stopping, his bowel movements have been permanently altered, and he's quite unhappy. On a good day, he'll have between 2 and 4 bowel movements with a Bristol Stool Scale 4, but on a bad day, which is also about half the time, he can have anywhere from 2 to 7 bowel movements with a Bristol Stool Scale of 5 through 7. No blood, he does have a lot of mucus, and no urgency or pain in his rectum. He has a sense of incomplete evacuation during the bad flare-ups of the looser stool. He has a lot of abdominal distension and bloating, and the pain is severe. Usually the abdominal pain is immediately prior to the episode of diarrhea. He's gained 25 pounds in the last year, which he attributes to this just overwhelming change in his life and the pain. He can't exercise, he can't eat the healthy foods that he's supposed to be eating. He does state that he's always had a sensitive stomach and he is prone towards bloating and diarrhea, but he's never had symptoms this severe prior to his infection. He has a lot of depression and anxiety and avoids socializing because of this. He is obese. He has occasional heartburn and fatty liver. He has a strong family history for anxiety, depression, and his mother passed away from a car accident when he was 10 and she was 40. He also was put on Lexapro in his early 30s for about a month and did not like it, didn't think it was effective, and so stopped it. He's currently on pantoprazole 40 milligrams in the morning for occasional heartburn, and his abdominal exam is unremarkable. He had, when this began, a couple months after this began, he had a CT scan and an upper endoscopy and a colonoscopy with the exception of hepatic steatosis, was normal. And a couple years before, when he was having, again, this sensitive stomach, he ended up also having an endoscopy and a colonoscopy and an ultrasound. So he's had a very extensive workup over the years that have all been unremarkable. So at this point, I'll ask the panel, what would the diagnosis be in this man with intermittent diarrhea and severe abdominal pain? And is there additional workup that's needed given he's already had endoscopies, CT scans, and ultrasounds?
Well, it certainly sounds like he has irritable bowel syndrome with diarrhea predominance. I would have asked when he had his colonoscopy, did he have random biopsies taken to look for inflammation? Though it sounds like his diarrhea is not daily, sort of in the pattern one would expect for microscopic colitis, but it would be nice to have known that, and often that will have been done.
And I forgot to mention that that was done. Actually, in both sets, he had biopsies, upper and lower, that were all normal.
Yeah, and so with the duration of symptoms and sort of the characteristic findings, you're probably not going to get a lot of additional information. The things that I usually like to look at in a patient with newly diagnosed IBSD is to make sure they don't have celiac is one, and I might get a CRP to assess for inflammatory factors.
So with mentioning with the CRP, he did have that. There was, I don't know if, Lynn, if you want to comment on Bill Che's study on the CRP.
Well, you know, these are what you would do before you get all the other things.
Right, exactly.
Now that
Normally
he's
it's the
actually
other way
had an
around.
upper lower CT, you really probably don't need this, because you're really basically trying to exclude IBD. So you have a normal CRP, normal fecal calprotectin, less than 1% chance of IBD. If you use them both together, it's even a little more of an additive effect. So this is really more that you would do as a screening along with celiac serologies. The only other thing to think about in him is whether you think he has bile acid diarrhea, which, you know, they estimate is like 20 to 40% of patients with chronic diarrhea, but I think it's probably less.
So he had the additional workup done, and when he comes to you, he says that he's very interested in diet. He seems to have this kind of all or none personality. So he did a Whole30 diet, and he said he felt fantastic during that. He had improved bloating, stools, pain, but he doesn't think he can maintain it indefinitely. And then someone brought up the idea of a low FODMAP diet, which he had never heard of, and now wants to know, is that a better option for him? And I'm actually just going to skip this and go directly to Nancee's talk on the low FODMAP diet.
All right, so most of you have probably heard of and maybe even worked with the low FODMAP diet. So I'm going to give you a little bit of the basic information about the diet and why it appears to be so beneficial for especially our irritable bowel syndrome patients. But then I want to give you a little bit of some of the newer research and information that goes beyond the basics of the diet that dietitians are using in clinic now. So I do have one disclaimer that I wanted to share. So the low FODMAP diet was created by Monash University in Australia in 1999, and actually what they did is they took research that had been out since the 1960s and they culminated these different sugars into one cohesive diet. And what we find is that there are 5 sugars, which I underlined: fructans, galacto-oligosaccharides, also known as GOS, lactose, fructose, and polyols. And this grouping of sugars seems to cause a lot of the symptoms that we're used to seeing in our IBS patients, including diarrhea, bloating, gas, cramping, and abdominal discomfort. So let's just take a minute and review these different sugars, where they come from, and why they seem to be so problematic for our patients. So the one that we're all probably most familiar with is lactose. We see that lactose issues are pretty prevalent in our society. This is a sugar that is a disaccharide sugar. It's found in all mammalian milks. This includes cow's milk, sheep's milk, and goat milk. And what can happen is patients can either have a reduced amount or lack the enzyme lactase, which helps them to break down this sugar molecule. And I always like to remind people that lactose malabsorption is not the same as lactose intolerance. So lactose malabsorption means that we are malabsorbing the sugar, we're not breaking it down appropriately, but it does not always mean that there will be symptoms associated with it. Intolerance means that there are digestive symptoms that go along with this. And so you can see that across all different ethnicities in the United States, lactose intolerance is pretty prevalent, but at the bottom of the list you see our IBS patients, and that's only about 25% are estimated to have lactose issues. And when we look at the research, it's pretty inconsistent. Just when we remove lactose from the diet of our IBS patients, we see results 29 to 75% of the time. That's a really wide spread. So removing lactose is a great first start, but it may not be the answer that the patient is looking for, which is why we then move into some of these other sugars. Fructose is the one we're probably secondly most familiar with. This is a monosaccharide that is only a problem when it is found in excess of glucose. So we've got lots of transporters in the body that are able to take in the glucose-fructose molecule. So that's not where the issue comes in. We have other transporters that just move fructose across the epithelium. Unfortunately, they're very slow, and they're also low capacity. So when we flood the body with a ton of excess fructose, the GI tract has a really hard time compensating, and this is true even in our healthy controls, so that we find that actually 1 out of 3 people will malabsorb fructose, but they may not experience symptoms from it, whereas our IBS patients, it looks that about 45% of them will experience symptoms from fructose malabsorption. And so you can see that when we look at different foods in the low FODMAP diet, we're paying attention to that excess fructose amount. So that's found in common foods such as honey, apples, asparagus, high fructose corn syrup, agave. And you can see in the chart listed that kiwi at the bottom has even amounts of fructose and glucose, so that is considered a low FODMAP food, whereas the honey and mango have excess fructose, and those are not considered safe options on the diet. We have fructans next, which are actually a prebiotic fiber. They are a molecule made up of fructose that are bound together. And the issue here is not one of necessarily malabsorption, it's that human beings lack the enzyme to break down these fructose-fructose bonds. So no human being is able to break down these sugars very well. The difference is that not every human being will have symptoms because of that issue. And what you'll notice is that there's quite a variety of foods that fall in this category, including our gluten-containing grains. So this is where wheat, barley, and rye are. So oftentimes patients think when they go on a low FODMAP diet that they're going on a gluten-free diet. And you may have patients come into your office, say that they went gluten-free, and they feel better, but it hasn't completely resolved their symptoms. And this could be a sign that they actually have a fructan issue. And they just need to go a bit further and remove more foods that contain fructans, such as onions and garlic and inulin and cashews and other foods that contain this same problematic fiber. GOS is the next category. This is another prebiotic fiber. This time it's made up of galactose molecules that are strung together. And we also lack the enzyme alpha-galactosidase as human beings. So there's a reason why when we all eat larger quantities of beans and legumes and soy products, there's some flatulence associated with that. And so we find that this enzyme missing can be very problematic for our IBS patients specifically. The last sugar category is polyols. They're also known as sugar alcohols. They're found naturally in a lot of our fruits and vegetables, including apples and prunes, things like mushrooms and cauliflower. But we also like to add them into sugar-free food products. So this is why sugar-free gums and mints and cough drops can potentially be problematic in terms of creating some of those IBS symptoms, especially diarrhea. And this can also be a problem for our diabetic patients. So when you have a diabetic patient who is complaining of a lot of diarrhea and bloating, check and see if they're eating a lot of those sugar-free chocolate bars and syrups. They probably are laced with a lot of polyols, which could be leading to their symptoms. And this is because these sugars are only absorbed through simple diffusion, but unfortunately, they're a bit too big, and so a lot of them get malabsorbed, especially if transit time, which we see can be increased in our IBS patient. If it's increased, then these sugars are going to just bypass those pores and they're not going to be absorbed. They're going to end up in the colon where they bring water with them, and this creates that osmotic laxative type of effect. And what we found is that even in healthy controls, absorption rates are maybe 25%, 30% of these sugars, so malabsorption is really high. And I like to point out, I put a label from a sugar-free gum, and it even says polyols may create a laxative effect on it. So they're forewarning people when you buy these products, they could have a big problem. The main sugars that are found in foods are the mannitol and sorbitol, but we as human beings make other forms of these sugar alcohols, including xylitol, maltitol, and isomalt. And I just lost my slides. Well, I'm going to keep going. So what is the issue with these different sugars? So basically, what we think is that when we put all of these sugars together, it fills this invisible bucket that lives inside of our patients. And as they eat and the sugars fill up, the bucket overflows. And once the bucket overflows, that is when they're going to have these characteristic IBS symptoms. And that's why it can be so confusing for patients. They're like, I ate this yesterday and I was fine, but I ate it today and I wasn't. And it's because they hadn't overflowed their bucket at that point in time. We also know it's dose dependent as well as combination dependent. So not every patient is going to have problems with every one of the sugars at the same dose. And so part of my job as a dietitian is to help figure out which sugars are problematic for them and at what dose. So what is the mechanism of action here? We don't actually know. We have a lot of theories and ideas, and these are kind of the big ones right now. We're pretty sure these sugars exert an osmotic effect. So we found that when sugar molecules have a degree of polymerization that's greater than 10, they're going to cause a laxative effect. So all of these high FODMAP sugars, lower than 10 degrees of polymerization will have a laxative effect. And we've even seen this in healthy controls. So when we give healthy controls a large dose of mannitol or a large dose of fructose, they are going to have increased small bowel water content because of this osmotic effect of these small sugars. We also believe that they alter motility. So we've seen that when we give patients a fructose-sorbitol mixture, that it is going to increase transit time. It moves very, very quickly through the small bowel and into the colon, and it brings a lot of water with it, which will then lead to diarrhea. These sugars are also highly fermentable, especially those prebiotic sugars that we saw. So when we challenge both healthy controls and IBS patients with inulin, which is one of our fructans, we found that the colonic volume goes way, way up. So they produce a whole lot more gas. And so this starts to beg the question of, do all the sugars act the same in the body? Should we be looking at them all as one grouping? Or with some patients, should we be thinking about them separately, that some of them cause gas, some of them cause bloating? And this is what we've actually seen, is that when we start to look at some of the newer research, so this was done in 2014, they had healthy patients take in either glucose, fructose, or inulin, and then they stuck these poor patients in an fMRI machine every hour for 5 hours. And what they were looking for was to see what the small bowel water content looked like and what colonic gas looked like for these patients. And what we see is these sugars didn't behave the same. So fructose, as we had mentioned, caused that distension, an increase in small bowel water content, whereas inulin was more likely to create that colonic gas. And so it really does beg the question, do we need to use all of these sugars and remove all of these sugars from these patients' diet, or can we start being a little bit more careful and individualized with our plan of care? And what we saw in a study that had a similar idea in 2017 was that with our IBS patients, it seems like visceral hypersensitivity is the driving factor and not gas production, because what we found when patients were given inulin again, and these are both healthy controls and IBS patients, they had the same results. So you can see the charts look almost identical. When we look at C, which is small bowel water content for our IBS patients and our control, the charts look almost the same. So they had increased small bowel water content with the fructose, and the same is true when we look at colonic gas and fructans. The big difference was that the healthy controls did not state that they had any discomfort or any symptoms. Okay? So this is how dietitians are now starting to think about this diet. We're really looking to see, do we need to be removing all the sugars? And the answer is no most of the time. So if a patient has constipation but gas and bloating, we wouldn't want to remove fructose and polyols because these are natural laxative and may actually help them to go to the bathroom. We would focus instead on the fructans and galactans and maybe lactose. And in reverse, if we had a patient with diarrhea who doesn't have bloating, we may want to focus on fructose, polyols, and lactose and not worry so much about removing these great prebiotic fibers, which actually would help them to grow the right types of bacteria and help to create a healthy gut microbiome. So who should be considered for this diet? Of course, our IBS patients, as well as anyone who's experiencing functional bloating or functional gut symptoms. And then, of course, there's a huge crossover, about 40% with our celiac and our IBD patients who are clinically in remission but are still having functional symptoms. So this is another group we want to consider. But why would you want to send your patient to a dietitian instead of just handing them a handout? So first of all, of course, is that we may not want them to be on the full low FODMAP diet. We might want to modify. For those of you who haven't seen the low FODMAP diet, this is it. And you'll notice that a lot of your favorite foods are here, right? And so it can be really, really confusing for a patient if you just give them the handout and say to go home and try and follow it. They also might get confused and think, oh, my gluten-free bread that I already have at home is safe for me, not realizing that it actually has 3 high FODMAP ingredients on it. Or they may go home and use their salad dressing, not realizing that it also has 4 high FODMAP ingredients. Or they may continue to take their calcium supplement, which also has a hidden FODMAP. And then, of course, that great probiotic they were told to take is also a hidden source. So we want to make sure that we give our patients really good information. When a patient comes to see me or my colleague Janelle Smith at UCLA, they not only get these high FODMAP and low FODMAP checklists, but they're also getting a full packet with a grocery list, meal planning, meal guides, as well as pitfalls, how to read labels, how to make sure that they are looking appropriately at this diet, because they're only going to be following it for 4 weeks. And that's another big key, is this is not meant to be a long-term solution. We don't want patients on this diet for more than, at the most, 6 to 8 weeks. I usually try and keep it at 4, and then we move them into, oh, I'm sorry, let me move those. We want to move them into the reintroduction phase because the whole point was we emptied their bucket during that first initial elimination phase, and then we want to actually figure out, well, what was filling their bucket in the first place and at what dose? So we send them through a very strategic and structured reintroduction phase where we actually figure out which sugars were problematic so that in the end we can liberalize the diet as much as humanly possible, and that's the diet they end up following. And since I'm running out of time, just really quickly, I wanted to remind people that there's more going on than just the FODMAPs. You may have patients who, unfortunately, even the lactose-free products, which are technically safe on the low FODMAP diet, they may still react, and this could be because of something called milk intolerance. Also, if your patient has issues with beans and soy and stuff like that, we may actually want to give them an enzyme instead of removing these healthy fibers from the diet. So I'll just move to the end. Thank you.
Thank you, Nancee. I think that's a great advertisement as to why giving your patient a one-page handout on a low FODMAP diet and sending them off is probably not going to work. So we started a couple minutes late, so we're going to end just a couple minutes late, but I wanted to jump pretty quickly to our next and last mini lecture with Dr. Tillisch to discuss probiotics, because many of our patients come to us, they want to take a probiotic, and they don't know which one to take and if it's going to help what symptom.
So probiotics, as most of you know, are microorganisms that we think have some type of benefit for us. The difficulty is most of the probiotics that you find on the shelf at the store have never been tested, and so we don't really know that they're pro. We're kind of going with historical evidence. Those that are most commonly used in irritable bowel or in functional dyspepsia are going to be the lactobacilli and the bifidobacteria, for which there is a little bit of evidence. And we can find the probiotics in supplements, but also people sometimes forget that eating yogurt regularly provides a source of probiotics, and there are many fermented foods in people's diets that also have probiotics, as well as the plethora of probiotic-containing and pricey beverages and other foods that have cropped up all over the place. So patients may be on probiotics already, and they hadn't really thought it through. So why might probiotics have a benefit for the body? Probiotics are thought to act in several different ways within the gut. In one, they may be involved in immune regulation, and certainly in early life they're involved in developing immune tolerance. But as you reach adulthood, they're probably acting to compete out pathogens or other bacteria that may not be pathogens, but may be more irritating or gas-producing or have negative effects within the gut. They also stimulate antimicrobial peptides like defensins, which is a little counterintuitive because that actually is not helping them as bacteria, but do help keep integrity in the bowel lining. And they increase the digestion of some components of our diets in beneficial ways that help the integrity of the bowel wall. So they're helping with maintaining the barrier function. In irritable bowel syndrome, just generally, there have been a number of studies over the last decade looking at, is there something different in the microbiota in IBS, and is this a rational thing for us to do to try to change the balance of bacteria? And though a lot has been learned, the take-home message is that we still don't have a lot of actionable evidence. One thing that I do think is interesting and may be useful in the future is that several of the studies have shown, as I show in that small graph, have shown that in IBS there's a group of people who look just like healthy controls in terms of their fecal microbiome. The bacteria don't look any different than someone without IBS. But then there are these other groups that seem to have something different. And that makes sense when we think about how people respond to probiotics, which isn't a strong response. There are a lot of people who don't respond. And so there are probably a group of patients with IBS where these probiotics and where the microbiota is not particularly relevant. At this time, we can't identify them, but hopefully in the future we will. There's another group where the microbiome may be playing a significant role. It turns out that at least in a couple of these studies, that group that looks like healthy, normal control microbiota may have more of the anxiety and depression and mood-related symptoms, allowing us to potentially separate out who you might send in one direction for therapy versus another direction for therapy. Probiotics generally have been proposed to decrease bloating, to improve bowel function, and to decrease pain. And in IBS, most commonly studied have been the lactobacillus and the bifidobacterium. Patients will come, though, with the idea that these will help all sorts of symptoms and that they're necessary for health, which has not been shown. So do they help IBS? This is an older study, but it's still the largest one and I think most helpful. They looked at a huge number of studies. They felt like the studies were overall of fairly good quality. And what they showed is the relative risk of symptoms persisting was about 0.7. So there was a small benefit with a number needed to treat of 4. It didn't seem to matter in this meta-analysis which type of probiotic they used. Was it a lactobacillus? Was it bifidobacterium? Was it a combination? Which is helpful to know. We looked at bloating, which is one of the things that often patients think that the probiotics will help most for. There was a non-significant trend towards benefit. So we think there may be some benefits, but it's not as strong. In flatulence, there was a benefit. In pain, there was a benefit. So probably across multiple symptoms, probiotics may be helpful. And we know, as in most diseases, there is the benefit of placebo. And I would say of the things that we take, the things that we talk to patients about, probiotics are one of the things they come in with the biggest potential for placebo. People really believe in probiotics for whatever reason. And so there may be a good placebo benefit. What about some of the other things we've talked about with IBS? Mood is a big factor, and we've talked about different ways we can treat that pharmacologically and with mind-body therapies. It turns out there are a number of studies that have looked at mood and probiotics and shown, small studies, not particularly strong studies, but have shown that there's a potential benefit for anxiety and depression symptoms. This last year, a group came out with a study looking at IBS specifically and looking at a particular type of bifidobacterium in mood in IBS. And mood was actually their primary outcome. What they showed were that over 6 weeks, patients with IBS had a decrease in their depression scores. They didn't see a difference in anxiety. They saw non-significant changes in IBS symptoms. And they also looked at the brain at the same time and found that the amygdala, which is where we feel fear, anxiety, and negative emotion, had decreased activity in patients who took the probiotic. So there's a possibility that patients who are taking probiotics may actually have some of their benefit by just feeling better in terms of their mood. Do probiotics help functional dyspepsia? There's less research on this, but it does appear that patients may benefit in functional dyspepsia for specific symptoms, and in this study, just a trend towards an improvement in overall symptoms. What are our current limitations? So right now, we're really in, I think, an area where there's just not a lot of actionable evidence. We don't really know what the best doses are. We don't know what the duration of therapy should be, though we do think that probably if a probiotic works, you're going to need to take it long term. It doesn't repopulate the gut. It usually is gone within a few weeks of stopping it. We don't know the best mode of administration. Is it better to have a probiotic in its natural environment, like yogurt, or is it better to put it in a pill? And we don't know how to individualize them. So it's hard to tell a patient specifically what probiotic to take. When I talk with patients about probiotics, I usually suggest that they start with a single species, so a bifidobacterium, for example. They try it for 3 to 4 weeks because these are small and effects that may grow over time. And that if it's not helping at the end, that they shouldn't continue it. And maybe try a different one. Maybe try 1 or 2. If they don't see a benefit, that probiotics might not be the right thing for them. My clinical experience has been that I see a lot of patients who have minimal benefit from probiotics, but just keep taking them, which I think is probably a waste of money for them. But I find a few patients that do incredibly well on probiotics. They have a significant improvement in their symptoms, and they'll stay on those. And so the key is to say, is it helping? And if they can't be sure that it's helping, then they probably shouldn't be on it. We have a few commercial preparations that have been tested. We definitely need more of that. And in terms of cost, this can get costly. Often people will gravitate, so it's a natural tendency that's well studied, to the most expensive one. They don't necessarily need the most expensive one, and I let them know about that. The ones that have been studied the most, for example, Align Bifidobacterium infantis is one that's been studied more. It doesn't need to be in the refrigerator. It's not in a special section in a special store. It doesn't have special packaging. You're going to find it at Target or Ralph's. So they don't need to have something that's particularly fancy as far as we know. So the take-home, they do appear to benefit some people. The benefit tends to be mild, but it can help global IBS symptoms, some specific IBS symptoms, and dyspepsia. We think the risk is low. People that we would want to avoid probiotics are people who have a very impaired immune system that shouldn't be having live bacteria. And which one to choose and which dose, we don't always know, but I tend to go really with the mainstream ones. In terms of the lactobacillus and bifidobacteria.
Thank you, Kirsten. So I know that there are a lot of topics that we have still not had a chance to answer, but in the interest of all of you wanting to take a quick break, I want to thank our panelists very much for this morning's discussion. I think they'll stay up here for a couple of minutes in case any of you have any additional questions. To wrap this patient case up, he loved taking the probiotics. He was referred to psychiatry. He also was started on Cymbalta, which if you have questions about the use of that, again, that's something we can discuss up here. So thank you again. I hope you enjoyed this session, and we will return at 10:20.